to the Intersection of Population Health and Social Care, Driving Better Outcomes webinar. My name is Alex Glujong. I am the Principal Enterprise Account Executive at Blooming Health, and I'll be moderating today's conversation. My work centers on supporting population health and quality improvement programs across East Coast health systems and health plans. Now, population has evolved significantly over the past few years. We've moved from identifying social needs to being accountable for addressing them, following through, and demonstrating outcomes. Now, today's discussion is really focused on how organizations are navigating that particular shift, how they're putting those things in practice. So what's changed, where things break down, what outcomes matter most, and how policy and payment models are accelerating this work. So we'll start with some brief introductions, move into a moderated panel discussion using a set core of questions, and towards the end, I'll briefly share how Blooming Health helps organizations execute population health strategies at scale and drive measurable outcomes across care journeys. So we'll close with just a very brief live audience Q&A. And yeah, so please feel free if there are any questions, drop them in through the chat, and we will try our best to answer them throughout the discussion or obviously cover them towards the end and follow up after. Let's dive in. So again, I'll briefly introduce each panelist and ask them to share a quick sentence on what they're most focused on right now. Starting with Dr. Pat Runnels, Chief Medical Officer for Population Health at University Hospitals.
Hey, great to be here. It's been exciting. I am actually transitioning from population health to a broader to being the chief medical officer of our Healthcare Transformation Institute. So that's a brand new change. Still very involved in the population health side of things, but very interested in culture change and serving the most underserved patients. So that's where I'm at.
Thank you so much, Pat. Proud to introduce Kim Blanch, Director of Community and Mobile Outreach for Beebe Healthcare.
Thank you, Alex. Good afternoon, everyone. It's a pleasure to be here. I would say our ethos here in Community Mobile Outreach at Beebe is to literally meet people where they are. We do that in a variety of ways, and then also incorporating their circumstances, socioeconomic, environmental, medical, behavioral, social circumstances that are in need of support so that we can provide the services and resources they need to optimize their health outcomes.
Thank you so much, Kim. And happy to introduce Zach Rabovsky, Director of Population Health Strategy and Practice Transformation at CareFirst.
Hey everyone, and welcome to everyone who's joining us from across the country. It's a pleasure to be here today. So at CareFirst, our mission is access and affordability. And as one of the largest healthcare organizations in the country, we do that primarily right now through value-based care. So that's my role at CareFirst, supporting our practice transformation work across our different lines of business and working on incorporating social care into our value-based structure and our transformation structure. And excited to be here today.
Thank you so much. And thank you all for being here today. Well, let's jump in. One of the first questions that I'd like to bring to the panel, and I'd like to start with Dr. Runnels, if that's okay. Pat, I should say. How have health systems changed the way they address population health over the last few years? So what are you doing differently today?
So probably when population health kind of started as a large area, it was highly focused on what I describe as managing to our accountable care organization, in particular our payer contracts, and it was highly focused on primary care. Which is to say, I got into the game about 7 or 8 years ago now, and everything was about working with our primary care offices, which makes sense. That's where you need to start. That's if you're going to build towards delivering high value care, you need to be in a space where your primary care team and apparatus is capable of doing a lot of the work, the kind of foundational work. Over 7 years, we've gotten pretty good at that. Our performance in a lot of our ACO contracts has been excellent, but we're now shifting towards as you hit the quality metrics that primary care has the most impact on. That goes well. There's this larger sense of how do you perform well overall in in terms of reducing readmissions, in terms of making sure you're managing chronic conditions well. And that requires you to shift your focus away from a primarily primary care focus towards getting the rest of your teams involved with population health. And so over the last few years, we've been starting to engage the specialists and different kind of groups, the hospitalists and the hospital groups, around introducing them to the culture of high value care, what that means for each of them individually, and to start to align the system level goals around performing and delivering high value care. Just as a quick final thought on that, there's a world where you can kind of I don't know, incentivize or create goals and align those within a primary care institute such that the primary care is working really hard to deliver high value care, and the rest of your system is working towards volume metrics, right? And you can actually do pretty well in a lot of value-based contracts without having to align those too much, but you'll hit a wall. And so we are now at the place where what we're looking to do is make sure everyone's clear about the types of activities that are going to drive high value care, recognizing that we still live in this kind of weird space where we want to do high value work and also still generate enough revenue to keep our systems going. And in that regard, that's been kind of a fun and exciting time. But people have really engaged from a wide variety of spaces in our system. They're, for the most part, quite enthusiastic around what they can do to really meet that mission.
Thank you. Really, truly appreciate the clinical perspective there. I'd love to kind of shift it over to Kim. I know obviously you are very much more ingrained in community health, so we'd love to hear that side of it.
Yes, thank you so much. And Pat, I appreciate that, all that you shared. And I also appreciate the depth of the perspectives that we bring to this webinar today. Having been, I'm a registered nurse by training. I don't think I mentioned that. So I've been in the role of in the programs that I lead to this day. And it's the whole person, whole community approach that helps support the clinical metrics is where we have the opportunity here in the work that we do in a rural county, federally designated rural, where there are an umpteen number of barriers that our patients are facing. And I look at the work we do through the lens of either the triple, the quintuple, or the quadruple and quintuple aim of population health, right? So we're looking at cost of care, the quality of care, patient outcomes, but then also looking at that provider satisfaction or clinician satisfaction, as well as equitable access or health equity, as that fifth component of the quintuple aim of population health, and recognizing that social barriers, social determinants of health, social drivers, the need for social care can drive up to 80% of our health outcomes. So it lends to that clinician satisfaction when we have the infrastructure in place to support patients through those social barriers, so that they can adhere to a treatment plan, so that they can afford their medication, they can get to a clinician visit. So that's one of the lenses that I bring to this. So that's what I would offer, Alex.
Thank you so
If I
much.
could I realized when you said that, just so people who don't know, University Hospitals is based out of the greater Cleveland area. It's a $6.5 billion healthcare system, serves about 1.5 million unique folks each year in Northeast Ohio, that covers everything from urban centers to very rural areas, just so people have that context.
Truly appreciate that. Zach, I'd love to open it up to your side with the payer perspective.
Yeah, we've been very intentional, I think, over the past decade or so, trying to build the capacity to really understand and care for social risk. We started our value-based care journey about 16 years ago with our PCMH program. And at the time here in Maryland, we had about 4,500 primary care providers. And this is a commercial program that was focused on reducing cost of care, shared savings model, incentivizing primary care to manage that total dollar. And for years, we saw our primary care providers, our health systems kind of address the basic stuff, reducing admissions, ED visits, improving referrals, medication management. But over time, I think we really started to learn the value of addressing social drivers of health and the importance of doing that in order to continue to really drive cost reduction and quality improvement. And it started with education. We had to kind of start from the beginning and really work to make sure our providers participating in our programs and in our value-based care programs really understood what we were talking about when we spoke about health equity and social drivers of health. We started building the data resources, giving them opportunities to assess their patient populations and really understand not just the market or the landscape around their office or practice, but who's actually attributed to you and what are the social drivers impacting their health outcomes. And now we're starting to see a shift with our large ACOs and our small primary care practices to start connecting those dots. We're not there yet, right? It's not perfect. There's a lot of work that still needs to go into supporting the member journey, but we're starting to see that infrastructure build slowly over time where we can actually help the members get to the care that they need to keep them healthy and well outside of the practice. Certainly challenges, right? I'm sure we'll get into that in a little bit as well, like who's responsible and who pays. But I think what we've seen in terms of the jump so far is a willingness and an alignment that we've got patients or they've got patients, we've got members, they're the same individual. And ultimately, our goal is to create that opportunity to make sure that that individual is getting the highest quality of care that they need and access to care when they need it. And this is one of the ways that we go about doing that.
Thank you. Really appreciate those thoughts all across the board. It seems as though one consistent theme really is that of what we hear today and across different partners is really that social needs are no longer peripheral to care delivery, and I'm sure you all agree. So second question I'd like to present. When we think about organizations and essentially what they struggle most today when identifying social needs, engaging individuals, coordinating with community partners, or follow through after referral, tell me a little bit in terms of obviously what those struggles are and how you all shape and think of solutions to address those.
So I'm happy to jump in a little and start to add into this conversation. And I think this will actually get at Marissa Taylor's question in the Q&A. I'll do an answer live there. So I want to pick up then on that thread. I think that Marissa's getting at. So what Zach was getting at is there's a growing Zach and Kim got is there's a growing need for us to be thinking about SDOH in a system like ours. We have actually a very diverse population within practices. We've got chunks of Medicaid with chunks of Medicare next to chunks of commercial. We've got something like 20 different payer contracts. It's so. Practices were set up not with those things in mind. We then started to address that some by creating something like a PCMH, we call it Advanced Primary Care, and we started converting our primary care practices towards having additional folks in there. We had social workers, we had nurses, we started adding those, we have clinical pharmacists. And I think what to the point Marissa's making is the resources to pay directly for the work that goes into managing social drivers of care and social drivers of health is not well built. And actually, just to riff on what Zach said, so you've got payers out there who are mandated by states and by federal government to start providing and building in solutions. And so we've got a number of active Medicaid MCOs in our state, for instance, in Ohio, who are trying to toggle between, are we supporting the providers building that infrastructure, or are we the payers building that infrastructure? And we're seeing actually a diversity of approaches there, which is leaving us start to think about what does it mean to build our infrastructure and how do we focus that infrastructure effectively? So, and I'll go back to the chain here. We probably, in an ideal world, are screening everybody for what their social drivers are. But as soon as you screen people, you ideally don't want to screen them for, say, I don't know, homelessness or joblessness and have them say, yes, I'm jobless, and then go, oh, that's tough. Good luck, right? That's not the answer you want to have. You want some place to refer them. And so you're trying to balance gathering that data with being respectful of having at least some way to connect them with those services. That volume play is a problem. That creates a lot of, just screening people is work. Just screening people takes time. And if you don't build in that infrastructure really thoughtfully and intentionally, you'll run into trouble. And if you don't have, and a lot of people don't have the money or extra money lying around to build in a lot of that infrastructure. In our system, we've started and tried to spend the most time on those who have the highest burden of disease. So that's where we started. So if you, so we are actively and proactively reaching out and saying, first, are you struggling with control of your chronic diseases? Diabetes, high blood pressure, heart failure, COPD, kidney disease, things like that. When we are engaging those folks, we are then pretty regularly and assertively kind of checking and trying to screen for whether or not they have uh, social nervous active SDOH, particularly severe SDOH, whether or not they want help with that, because not, some people will say I'm homeless, but I'm staying with my uncle, and that's okay for right now. Um, and then working with a kind of a fleet of CHWs who work kind of virtually and for the most part more universally covering the service to pick up those referrals and start to work with folks. And so we've had a decent amount of success there, but the reality is that's short by a lot of what we would need to serve all the needs of all the folks and drive the best possible outcomes. We certainly are starting to look at, and in our region, what we have is a conglomeration of Medicaid MCOs that have come together to start to figure out ways to create payment codes. We have a pilot going on, a hub model in Cleveland, where there are pathways for solving social SDOH. And if you adhere to those pathways in a certain way, there's a rate that gets paid by kind of a convening organization called a hub that has allowed us to start thinking about what it means to build a workforce that can build for those things. So that's one mechanism in our region that has allowed us to start looking at growth of our CHW group. But other than that, the other pieces we're looking at, and I'll stop here and let other people jump in, but we're looking at technology to kind of help us with that as well. Alex, I think that answered your question. I don't know if that was exactly what you're getting at, but I think that got there.
No, it surely did. And yeah, Zach or Kim, feel free to jump in and share any of your insights.
Sure. Yeah, I'll jump in there, and I think Pat hit on, or at least started to hit on, like the financial piece of it, right? Who pays for
Yeah.
it? And we have to think about that as a challenge, because I don't know if that is totally ironed out right now. You can look at non-visit based encounter payments and value-based care as one of those opportunities to reward work in this area, but not a lot of value-based care models aren't yet built that way. We're heading there. But beyond that, I think when we look at some of the smaller practices, rural practices, independent primary care, the question often becomes, whose responsibility is it to do this work? Not every primary care office have the resources to dedicate either an individual or a team to supporting these types of efforts, whether it's the screening or the follow-up. Certainly, we want the screening happening in the office. It's an important piece of understanding a patient, right? Ability to understand what's impacting them outside of the office and consider that social risk as part of their treatment plan. But then they have to have the resources to connect that patient or help manage some of those risk factors. And if the staff isn't there or doesn't have the infrastructure or the tools in place to do that, we often hear, what's the point of even screening in the first place, or asking those questions because I can't do anything about it. So something that we've done with our independent primary care providers is try to connect them with the right technologies and the right tools to give them access to resources in the community. There's a lot there. There are a lot of community-based organizations all around our state in particular, and certainly I would imagine there are in other areas as well. And there are tools that are able to capture what those organizations do, what benefits they offer, maybe even government-sponsored safety net opportunities for financial, legal, housing support, whatnot, and making sure that those providers have a workflow in place to address it. And then beyond that, there's a communication issue as well, right? So you make a referral, do you just leave it there, or is there an opportunity to build that channel and lay that track down to get the communication back? I think if you really want to follow up on a member and make sure they're getting the care that they need, if they're receiving services outside of your office, we have to make sure that information gets back somehow. So building those connections is important, and probably one of a bigger piece of what we'll be working on in the future to make sure that those opportunities exist.
Thank you, Zach. It seems as though there's a trending theme here, right? It has a lot to do with the struggle being surrounded around scalability, and it seems as though
Mhm.
certain strategies around supporting those teams and or figuring out different ways of either, right, just focusing in on, as Pat mentioned, more of those higher need individuals, and then at the same time, um, obviously enabling or empowering your teams with some technology and other, resources to really lay that foundation, that infrastructure, and then obviously execute on outcomes. But Kim, would love to make sure that you're included in this topic because I know you probably see this on a day to day.
Thank you, Alex. Yes, I would just like to pull a couple of threads that Zach and Pat brought
Mhm.
forward. In addition to the technology and the tools, those are critical. I would also highly recommend or advocate for training of the individuals. I think
Mm.
it was you that may have mentioned, there, and not, these are not your words, but what we have noticed is that there's a need for increased comfort around SDOH screening, and also
Mm.
where it's being conducted, by whom, what their comfort, confidence, and competency is around that assessment itself, because there can be sensitive questions or a sensitive topic that arises as a result of a question that you want to make sure that the individual has the knowledge of how to manage that or identify when to refer out for something that might present in those assessments. So I think that's the training. It goes along with the tools and technology. I would also look at how we can create, for us, I'm part of our population health umbrella. We also have care coordination, we have chronic care management, we have our value-based care team, closing care gaps. And there's, one thing that's a pull through is the longitudinal piece.
Mm.
Because through some of our programming, we're engaging with individuals. Our food prescription program, and Vic, I saw your work, so I'd love to connect with you. But our food prescription program is a 6-month engagement, and a CHW is the coordinator of that program, and she assesses on the weekly how their circumstances may or may not be changing for the, to the positive or to the negative. So, and
Mm.
needs arise, right, over the course of that longitudinal engagement. So I think that longitudinal piece is also important, or at least a scheduled cadence of SDOH assessments, so that any rising needs or ideally met needs can then be removed from their assessment. So those are some thoughts that I would add to that. Thank you.
Thank you,
Uh,
Kim. Rounding us
a,
off with
qu-
compassion, right? So yeah, go ahead, Pat.
a quick add on to something Zach said, agreeing with what Kim said. I think it is the case that what you're trying to see is, from a pure funding perspective, you are seeing payers trying to think about what it means to pay for it. It's really hard to track solving SUH directly back to shared savings. So that's not an easy way for health systems to say, well, we'll pay for this. Because we'll make an extra, 100,000 on this contract for solving these, and that'll pay for us. I don't think people think the scale and is easily backable, and it takes some time to hit. So I think there is this question, and there are open experiments around what are the different mechanisms by which people get reimbursed for this stuff. That is still an ongoing experiment, and I think there are experiments going on around the country. I do expect that 5 years from now we'll have this will be solved because it's not remotely mysterious. Payers do want this stuff to be addressed. It makes sense for them, and that's what the policy in the country is moving that way. But we're not yet. We haven't figured that out. I just think that's worth pointing out.
Thank you. Really appreciate that last insight there, especially when it comes to having the full perspective of I would say how to obviously reach these outcomes, right? So ensuring that what exactly would be the best maneuver and how each one of your roles obviously is influenced with that. But naturally kind of leading the question and the discussion into outcomes in general, would love to hear a little bit about what outcomes actually matter when evaluating social care programs that you all are developing or obviously executing on. So whether that's from clinical metrics to operational efficiency and financial performance, would love to hear from you all. And yeah, I will change it up. Zach, if you don't mind
Sure.
starting.
Yeah,
Yeah.
I mean, for us, and I think for many others, we have to think about those leading and lagging indicators of success. And I think it's easy to point to the leading indicators like screenings, touch points, referrals. Those are really important, right? You have to be able to monitor how much something is being used if you've set up, a certain process or an infrastructure. But at the end of the day, what we're really looking at is, did we improve access to cost-efficient and equitable care? Are we seeing an improvement in health outcomes and a
Mm,
reduction in high cost services related to managing, let's say, chronic disease? So if we're setting up those infrastructure pathways and those processes that do that, and we're not getting those outcomes, then I think we have to reassess and we have to be ready to pivot quickly and figure out what's going to lead us there. But from a clinical perspective, and maybe I'll let the clinicians jump in there and get their sense of kind of what clinical outcomes relate best to success in this area. We continue to use those just like any other quality measure. I think again, as those leading indicators, are we improving outcomes? Are we adding value by seeing the benchmarks hit that we want? And I see this work more as more of a lever to pull in order for us to get there.
So I would jump in. Thank you, Zach, for that. From a clinical perspective, and also have some thoughts around operational and financial. But starting off with the clinical perspective, again, here we are in a rural county, 950 square miles, and a transportation system that has a lot of opportunity for improvement. When we're looking at clinical outcomes through the social care lens, right now our top four, it was always the top three were food insecurity, transportation, and housing. And recognizing there's a housing crisis across our country, not just in our county, but we certainly lack affordable housing here and any workforce type housing. One thing that's also presenting is financial assistance. People are having a really hard time making ends meet. And what happens there, in our experience, and this is very patient centric, is that they can't afford their medications, they can't afford their
mm,
copays, they can't afford to put gas in their car if they have a car to get to their provider visit, clinician visit. So it's really looking at ways that I always say to my team, we can't solve for everything, but let's solve for what we can so that the resources an individual has, they can reallocate to what we can't solve for. But really looking at how the social circumstances of a patient impacts their capacity to adhere, which then impacts their health outcomes. So I would also mention that operationally, we're looking at if we can address those barriers, then we are reducing our no-show rates, right? Which again
mhm,
has a direct result in improving health outcomes. We can increase engagement in our high SVI communities, right? When we're actually listening to people, assessing them for what their needs are, and they have the sense of being heard. And then if we can take action to assist them in eliminating a barrier or two, then we likely have increased engagement and trust, which trust, I always say our mobile units move at the speed of trust, which they do. You can't just show up, you have to build that trust. Also, faster transitions of care. And then, referral, just having the success of referrals that bodes well for our workforce, right? Because they have that sense of satisfaction and that they're actually able to assist someone, because it can get a little frustrating in the housing need arena where we can't always solve for that, but let's solve for what we can. And then, just how that impacts the total cost of care. So I hand it over to Pat. I imagine you might have some thoughts there.
There's some interesting threads that got pulled up there. It's fun as you get in these conversations to kind of think about this. So one thing that we ask ourselves is, what are systems for? What are we for and what are we not for? And so when it comes to SDOH, um, I feel strongly about this just as a human, not necessarily in my role as employment, which is health systems shouldn't be the caretakers for solving all SDOH for everybody. That's not really that. just because we spend a lot of money in healthcare and maybe less than some other countries on, on some of the solutions doesn't mean that's how it should be. But there is the flip side of that is there's absolutely spaces where we are the most important connector, and often, and I think Kim, you reference this with the Food for Life stuff. We are best positioned to solve for social drivers, right? And in those cases where I would say burden of disease is both high and complex or complicated. Um, I'll use an example. You said you mentioned it, so I'll use an example. We have a 340B pharmacy, and when people have trouble paying copays, our 340B pharmacy has some policies that allow us to be basically do financial assistance for people where copays are a barrier on the Medicare side, right? And that's something that was really obvious to us for our high disease folks that we want to do that. It's a mechanism that allows us to kind of afford to be able to do that. But what we do in that space is we then provide clinical pharmacy services. Those clinical pharmacy services are intensive longitudinal. Again, Kim, picking up another one here. They're longitudinal and they track with people to not just give them the resource, which is this really important solve to social driver, but also make sure they're using the med correctly, understand what's getting in the way of them using the med, so on and so forth. And that's resulted in some really good performance around diabetes control, kidney disease management, and a number of other things we do. I say that because some of the solutions we should be providing, lots of solutions we should not be providing, but we should be really intimately involved and be maybe the quarterbacks for getting people connected. And then there's lots of folks who have real issues that if it comes up for us, we ought to be moving them through and pushing them to the right solutions. And anything we can do to make that efficient is good, but don't necessarily need to be our responsibility. I'm sure the payers that like Blue Cross, Blue Shield that are represented here, have the same thought is let's invest in the folks where where we think this is going to unlock their potential to do well with chronic disease management or just chronic condition management of any kind. I think those are some of the questions we're asking, and that's kind of how we're thinking about where we deploy those resources and not. But it also dictates how we, and again, to pick up on the last thread you said, Kim, think about building trust within the community. We are not the only part of the community that needs to have trust. The patients are swimming in communities, particularly if they have a lot of SDOH, where trust is an issue, not just in healthcare, but everywhere. They don't trust healthcare. They don't trust the criminal justice side of things. They don't trust courts. They don't trust. They don't trust. Sometimes the CBOs, and I think that got referenced here, are the most trusted people. Those are people who are the kind of the least judging and doing the most to kind of help people in their real lives. I do think we in healthcare have a role for elevating CBOs as being central pillars of the community, and anything we can do to kind of promote. We have a giant organization called Greater Cleveland Food Bank, and I say giant in terms of food insecurity. They're awesome, and they should be a hub for a lot of people because that's the right place and the right set of people to solve their problems. But we can't all do everything, and we ought to be a lot more thoughtful about that wider web of communication. So we're coordinating, make sure the right people are becoming the right foci, I guess, of solving problems for people where they're best solved.
Yeah, and just to kind of hit that point home, I certainly agree with that, and from the perspective of our organization and probably many other payers, there is, I think, that need for alignment across payer, provider, community-based organization and government programs as well. And you're right, it isn't anyone in particular's responsibility to make sure that these happen and are successful, but they have to be kind of a shared interest and shared support because we've got the same individual that all four organizations are caring for, and we should also have separate metrics that we use to judge success in that as well. They're not the same metrics across the board, and what a health system uses to measure success may be different than what the payer uses, which is certainly different than a community-based organization or a government entity tracking the health and wellness or general well-being of individuals in their jurisdiction. Great points.
Mm.
Thank you all. Really appreciate it. And I truly love the fact that we're uncovering some of these strategies that you all, I'm sure, have applied mainly because you have a good understanding of your populations that you serve, but so allowing this forum to get a good understanding and share some of those strategies and thoughts across the board to other maybe health systems is really valuable. So really appreciate the time again. Wanted to dive into something around what we call here in Blooming Health, somewhat of a trendy word, right? So closed loop referrals, right? So closing the loop. Love to hear a little bit of what that closed loop actually looks like in practice. Because I feel, essentially that's really where, organizations find the breakdown during care transitions and really supporting the population as well. So yeah, happy to kick it off with Kim. Would love to hear a little bit of your translation of closing the loop.
Yes, thank you, Alex. So I first of all, I love the term because it feels like success, right? Closed loop, like you did it. So for us, I would say that a true closed loop means identifying a need, referring the patient to that resource in whatever mechanism is available, confirming the patient's received the service, and then obviously documenting that work, right? As a nurse, if you didn't document it, it wasn't done, right? You have to document. And you want to ensure that outcome. So that's the piece I think that's also critical to the increased or improved health outcomes is following up to ensure the need is actually resolved, that it wasn't just a resource connection, that the resource was appropriate and available or digestible by the individual, right? Sometimes we have these grand plans, but if an individual or community can't digest it, then it can fall flat. So making sure that the resource actually resolved the need. I would say that is, that's critical for us in a closed loop system.
Yeah. Zach or Pat, any thoughts?
I'm happy to jump in, Zach. I don't know how much you think about this. So I've slightly unorthodox thoughts about closed loop. There's been a lot of focus around closing the loop, and I totally agree with closing the loop as being this really important data point. At the same time, there is work that goes into closing the loop in and of itself. Meaning, so anytime you say we're going to make sure the loop's closed, you now have signed yourself up for a series of activities to ensure that the loop is closed. Can you reference the documentation piece? There's got to be a communication piece. To communicate, you have to set up mechanisms for communication. That often means new products, new things that go in there. And I say all that to say closed loop is really important. And also, if you spend a lot of time worrying about how you didn't close the loop or documenting that you closed the loop, that's work that is taken away from connecting more people with services in the first place. And I think they're both important. I want to connect as many people to services as I can, and I don't want my um, effort to ensure the loop is closed to overwhelm me so that I'm providing less connectivity to people. And people can ask me more questions if that doesn't quite make sense. But the point is, the more I spend time worrying about whether or not the loop's been closed, the more, and I'll get back to that in a second, the less people I'm engaging because I'm spending time closing the loop. So the trick, the balance, the challenge for our future is how do we minimize the effort involved in closing the loop while so that we can direct as much energy as possible towards the other pieces of it. And I think that's where this is where the tech becomes really important. How do the solutions that enable that communication reduce friction? For one, there's a lot, you could get really into all the ways in which the loop wasn't closed. I think, and then you can manage to that in a very distinctive way. I personally would rather just get communication that someone got a service and be able to move on. And so anything that can allow me to get that communication. And in a big system like ours, I don't know how Kim's system is. I'm sure Zach's the same way. As a big system like ours, we can receive data and have a data science team and a data analytics team that can kind of drop that data into a place for us to analyze. That's less of an issue, but how do you make that visible in a way? But actually, I don't want it to be visible if it got closed. I only want it to be visible if it didn't get closed, and I only want it to be visible for the right people. So there's a lot of work. I say all these things. There's a lot of work to make sure that work doesn't overwhelm you. And that's actually, again, I think that's the central technological concern of this mini era of SDOH. It got kicked off, I don't know, 5 or 6 or 7 years ago with kind of a first generation set of technologies. And I think we're in this place now. We're like, uh-oh, we've got this problem. They seem really awesome, but they're a lot of work. And how do you balance that?
So let's dive into, I think, the work a little bit
Yeah.
more, because I think you're absolutely right, Pat. But I was kind of thinking through, all that goes into this process as you were talking about it. And oftentimes it's, you start by paying for some new tech. So there's a
Yeah.
financial investment, right?
Yeah.
Then you've got to train staff members or someone in the office or
Yeah.
a provider has to take time out of their day to learn. And then you're taking them away from potentially another very important function in the practice that they were already doing that now they have less time to spend, which may be just as important. And then you have to get really good at selling the referral or the tool to a patient and convince them that this is what they need to do next. And then potentially have someone hand it off as well, right? So you're investing a lot of time and money into something that if you don't close the loop and allow yourself to measure, you won't know if it's successful. And that may become a waste, right? There's no opportunity to iterate. There's no opportunity to make those tweaks and figure out how do we improve on some of those processes. So that closed loop piece is valuable. Does it have to be the same method every time, right? As Pat was saying, do you need to know if the loop was closed or not closed? What's more valuable? Great thoughts there. Probably knowing it didn't occur is most important to understand, why, but also knowing when it does, again, allows you to measure the success and what leads to greater success in the future. But I was also thinking about the reporting piece, and I think there's an opportunity for payers to support that as well. We have data, as long as information is getting back to us. I think about the future of value-based care reporting, and if non-visit encounters and metrics of that sort become more regular in our payment models, and we're going to have to produce information on that. And that could be one method that we use to share back with providers. But we got to see more use, right? It's got to become more regular. It's got to be something that's worth investing in, I think, on both ends. Um, Pat, you had mentioned that in 5 years you think we'll be there. I agree. I think we're moving in that direction, and we'll continue to build out our reporting tools to be able to share more information on, those closed loop activities and whether or not they were successful.
I do think, and just to make sure to clarify a point, closed loop data is necessary and important. I think it is the nature of who gets what data when, where that gets put. There's a difference between my analytics team, and I use that phrase very loosely, being able to analyze our overall performance and our overall utilization versus the frontline clinicians doing the work and what they see. And I'm less concerned about our analytics team can handle, and I'm more concerned about our frontline clinical team can handle. And that's the piece where I really think we need better thoughts around that. But no, it's yeah, just to be very clear, it's very critical, but it's also very critical about exactly how detailed it is and exactly who sees what.
Yeah, who and when, absolutely.
Yeah. Yep.
Alex, can I jump back in real quick?
Yeah,
Just
please
all
do.
thoughts. Thanks, Zach and Pat, for just, I think what's coming to mind for me or what's presenting for me is the fact that it's complex, right?
Yeah.
And it's multifactorial. And what comes to mind as well for me is that the importance of multidisciplinary teams
Mm.
when we're managing patients, right? So in Delaware, I'm not sure what it looks like in Cleveland or in Maryland, but in Delaware, we are looking at state certification for community health workers. And community health workers ties into that peer model, right? Peer models are so efficacious, and community health workers do amazing work, and they do essential work. And we were able to stand up, thanks to some ARPA funding several years ago, a community health worker program here at Beebe. And we value that part of our team, those individuals on our team, because they can then and I also have a question that I'm just gonna propose, but they then can be that part of that frontline team, right? That can create that longitudinal engagement, and we find that to be quite efficacious here. I will say, with the support, clinical support, right? Because patients' situations change, and there are clinical needs that evolve. So that multidisciplinary approach is very important and impactful. And then the question that I just want to throw out there is I often wonder where the opportunity is for there to be patient engagement in this referral process, but patient engagement in a way that's almost reporting back to, where does the patient own part of this? And I mean that in an empowered way. Like we don't want to put the onus on the patient because we find, right, history has shown us that when you hand a patient a card or a brochure or a flyer about a resource, they, if they're being discharged from the hospital, they were just in an acute care setting. They're not well or they're recovering. So how do we then, in more of that population health approach, particularly in medical groups, how do we leverage the patient in an empowered, accountable way to participate in this and aid in data collection? Maybe
Kim,
they report that the loop is closed, that the resource met the need. Just a thought that just thought I'd throw out there.
Mhm.
yeah,
I
fantastic.
love that, by the way. There's the group out of Oregon. We've tried to pick this up a little. Group out of Oregon a number of years ago actually created a mini SDOH screen that was 2 questions. It had like 10 categories and said, "Do you have any problems in these areas? Just answer yes or no." And then the second question was, "Do you want help with it?" And the point of that was to like it was, we can ask all these questions, but if it's not unusual for somebody, well, I do have this problem, but I don't need help. Like so we were so busy gathering the question and then not determining whether or not they need help, which is goes to your point of empowerment. And I think another quick story, not perfectly emblematic here, but we had a guy who was homeless. He was in a shelter and we were working with him and we kept trying to solve his housing issue. And he would go to the ER with a real health issue. They'd refer him to the housing agency, and a social worker and a CHW put a lot of really good time into getting this person connected with a agency that could find housing for him, and he would no show. And we actually deployed an outreach worker to go talk with that person, and the results of who then determined they were homeless and connected to the same resource, and that person no showed again. And when the community that when that outreach worker went and said, "Hey, dude, what happened, man?" The guy said, I don't have a job, but I don't have a home, but I don't want help paying for my home. I want to pay for my home on my own. I want help getting a job." And to your point, we often misunderstand. This is the great work that CHWs and social workers for years have done. We misunderstand how much people want to be determining where their life path is and how much they don't want to feel as if they're just a charity case. And in this case, that we actually then shifted our focus, helped the guy get a job, and like 3 weeks later, he found his own place and put his down payment down because he was getting a paycheck. And it plays right into what you're getting at. And it's I think a great way to go into the questions, Alex, just think where you're going. But I think that's such an important point, is making sure people have agency in their partners as opposed to passive recipients.
Really appreciate that and love that that real world success story. So
Mm.
yeah, I will say that this obviously really transitioned as well into the next stage of the webinar, where I'm going to share a little bit more about Blooming Health and how we essentially can help keep that patient in the center, right? Make sure that their voice is heard within this journey. So I'm going to give our panelists just a brief rest while I dive a little bit deeper into Blooming Health. So please continue to have some questions roll in. We will dedicate a little bit of time to potentially answering those towards the end. But just jumping right into it, I want to just really start with Blooming Health's focus, which is really truly on removing barriers to care by intersecting clinical and social care in a way that is equitable, efficient, and scalable. So the goal isn't more tools, it's better execution. Our AI-powered care enablement workflows are designed around the priorities that matter most to health system and health plans. So first, they improve screening and needs identification, some of the themes that we've touched on today, where we've seen organizations roughly reach 35% higher completion rates. This ensures that fewer individuals fall through the cracks. Secondly, the workflows enable proactive navigation to benefits and services, so helping address social needs earlier and reducing downstream utilization. Third, all outreach and follow-up is automated, right? Consistent and fully documented, supporting care teams, management efficiency, quality reporting, and health equity initiatives without adding burden to staff teams who are already at capacity. Again, some of the things that we covered today. And finally, the workflows support sustained engagement over time. So not just that one-time outreach, right? Keeping the voice of the patient, of the member within this journey, which truly is critical when managing chronic conditions, maternal health, care transitions more effectively. So at the center of our platform is not a single AI feature, but a set of purpose-built AI agents. So each is designed to handle a specific part of the care journey. We use dedicated agents for outreach and dialogue, screening and surveying, scheduling and reminders, and escalation or redirection. Because we understand that human intervention is necessary and may need to be involved when escalating. We also know that there may be alternative pathways that may be needed and want to make sure that we're routing them cohesively. So rather than one agent doing everything, these agents work together as a coordinated workflow. They optimize each step based on the outcome they're trying to achieve. So for example, if the goal is improving A1C control, the workflow emphasizes sustained engagement, education, follow-ups, and timely execution and escalation. If the goal is reducing readmissions, the focus then shifts to post-discharge outreach, appointment adherence, and early identification of barriers. So by orchestrating multi-agents toward a defined outcome, organizations get more consistent execution, better engagement, and measurable impact without adding, again, operational burden, really being an extension of those care teams, not in any way replacing them. Blooming Health delivers this through a platform built on integrated layers of care enablement. It starts with the digital communication layer. It uses multimodal outreach, so that's phone, text, email, it could be IVR, and along with that, an empathetic AI conversation. We use AI sequencing touchpoints so that the engagement is timely and continuous. Our engagement methodology layer personalizes the journey. So whether that's based on clinical risk and social context, it's able to automate the best practices of high-performing care teams. A built-in health equity layer ensures that we're able to reach across 80 plus languages and multiple channels. So meeting those patients, those members where they are. And through our social care network, we identify needs surrounding food, housing, transportation, and so on a lot earlier and connect those people to local resources and track resolution. So finally, our outcome confirmation, that closing the loop, and integrations layers really allow for more visibility and connecting that information back over to the EHRs in the manner that they would want to receive that information, and ensuring that it's one single pane of glass through this care journey. Now, since our inception back in 2020, we stood up a countrywide network serving over 5.5 million members, individuals, across 1,250 plus customers and community partners, and across 26 different states. So some of our partnerships span across impactful organizations within healthcare, government, and social care, like the New York State Office of Aging, which covers 39 different counties across New York, through our partnership with the AARP Foundation with a 10-state reach, and along with that, the social care networks in New York City who support the Medicaid and Medicare populations. And in practice, organizations see measurable impact. We improve efficiency for care teams. We have higher engagement. We promote stronger follow-through and better access to benefits and services. Outcomes are customizable and based on organizational goals. So in short, we operate at the intersection of clinical and social care, making it possible to understand the whole person journey, act early, and deliver the consistent follow-up that turns better access into better outcomes. So thank you all. We'll open it up for audience questions. Take a quick peek at the chat if there's anything that stood out to you all panelists, but if not, I do have some others that I can dive into. I know we've got 5 minutes, so I want to make sure that we're just conscious of time. Well,
I was going to say, thanks, Alex. Let me pull this question for our panelists from the Q&A submissions. How do you work with or on behalf of the community organizations in your area so that you don't inadvertently overload their capacity? That's a great question. And they add, we have realized issues regarding this in our community as a result of widespread screen and navigation of Medicaid.
A quick response I have, which might be slightly unsatisfying to this person, is where we are as a large health system in terms of screening and referring is a general rule, and I think this is true for a lot of health systems, health providers directly, much better screening than we are at the mechanisms of referring. And so as that, I think this will become a bigger problem as we get better at referring. I think the direct work Kim does as we scale that and get better at that, or better versions of that, or take products like blooming and are able to scale as a result of technology, I think we'll start to see that problem. And we've had our CBOs tell us they're concerned about this in the future. At the same time, uh, there are other events that are taxing them more than our referrals right now. For instance, the food benefits change, SNAP benefit changes are causing a much bigger disruption to certain CBOs than any increased referrals we're making. That's not to say we aren't there and we aren't increasing to those burdens, but that's a little bit of what my answer is right now, which may again be I think that's a problem that's coming down the road for us that we haven't massively run into yet. The other piece I'd say is there are housing is there's not enough housing, and that there's not enough housing solutions. There's not enough housing, even in Cleveland, which actually has a decent amount of like our housing shortage isn't as severe. That's just a resource that we never have had enough of. So the fact that there's a longer line there's just a longer line for the relatively limited services that exist. So there's that piece of it too.
Thanks, Pat. And Alex, I'd love to hear from you a little bit about how blooming can help with overloaded capacity for these teams.
Yeah, absolutely. It really has to do with the way that our technology can really take on a certain cohort. So really identify what those populations look like, some of the priorities centered around maybe harder to reach individuals, or if you're looking to, again, kind of dive into specific outcomes, whether that's improving chronic conditions or if maternal health is really what, to be fair, is the biggest, challenge at hand. What we can do is really support automated outreach and kind of enroll them into one of these care enablement workflows that was really able to support them through this journey. So really meet them at those critical points of either ensuring that they're able to make a follow-up appointment, right? If for instance, a mom and baby may need to have transportation support to ensure that they are able to make the post-delivery appointment coming up. We're able to kind of tap in, right? Take on some of that work from the care teams and reach out to those specific patients to have a better understanding if there's certain barriers that are blocking them from getting access to care. Yeah, it's a continuous workflow. So it's really designed to make sure that it isn't just that one-time outreach. It's really understanding at each particular stage of their care when is best to engage with them, what are the best tools at hand, what can we uncover, and how obviously to connect them best to those services that will make sure that care is delivered. So I hope that's helpful just to really share a little bit about how we can really support expand capacity for some of these care teams, take on some of that work and so on. Well, I know we're somewhat about a minute away, actually just turned 2 p.m. So perfect timing. I really want to thank the panelists for the such a thoughtful and insightful discussion today. And thank you all for joining us. The intersection of population health and social care really is no longer conceptual. It's operational, measurable, and impactful and essential. So appreciate your time. Happy to kind of follow up on some of the questions that we may have lingering in the chat. We'll follow up separately. And yeah, looking forward to continuing the conversation. Thank you so much.
Thank you, everyone.
Everyone.
Thanks.